Hello everyone, welcome back to another session in dentistry and more. So let's continue our components of periodontium. So today's topic is about cementum. This will be dealt in a few parts. So this is part 1. We are dealing about the basic physical properties and its classification, types cellular and acellular, and the cementogenesis and mineralization part. So the gingiva and periodontal ligament, the soft tissues of periodontium, we have already finished. Now we are moving on to the hard tissues of periodontium, that is cementum and alveolar bone, and today's topic is about cementum. So let's see the details of cementum. So cementum is a calcified avascular mesenchymal tissue that forms the outer covering of anatomic root. Okay, not the clinical root, anatomic root. So it is forming the outer covering of anatomic root. This definition was given in Carranza, and we have basically two main types, that is acellular and cellular. And it begins at the cervical portion of the tooth at the Cemento enamel junction and continues to the apex. Okay, so it starts here and it continues to the apex. So it covers the root basically. So what are the physical properties of cementum? So the hardness is comparatively lesser than dentine, which is very yellow color, which lack luster, which is light yellow color and which lack luster, and lighter in color than dentine. However, it may not be distinguished on base of color alone. So the permeability of cellular cementum is greater than that of acellular cementum. We'll see in detail about these two. With age or the advanced age, the permeability of cementum decreases, and the cementum is thinnest at Cemento enamel junction, that is here, Cemento enamel junction, and it is thickest towards the apex. So at Cemento enamel junction it is 20 to 50 micrometer, whereas at the apex it is almost 3 or 4 times, that is 150 to 200 micrometer. So that's about the physical properties. Now let's see the composition. So the basic dry weight basis, we can say 45 to 50% of inorganic substances, which consists of basically calcium phosphorus in the form of hydroxyapatite crystals, that is a inorganic portion, and whereas a 50 to 55% of organic portions with organic material and water. So organic matrix of cementum basically consists of type 1 collagen, type 3 collagen and other non-collagenous proteins, whereas the type 1 collagen is the majority, just like periodontal ligament. If we say by volume, we can say 45% of inorganic matter, 30% of organic matter and 20% of water. That the first one was dry weight basis and this is by volume. So the two types of or two sources of collagen fibers are present in cement. One is Sharpie's fibers or extrinsic fibers, which are embedded portion of the principal fibers of periodontal ligament formed by the fibroblast. So we had studied the Sharpie fibers in detail in periodontal ligament. And the second one is fibers which belong to the cementum matrix. They are intrinsic fibers and produced by cementoblast. Okay, so extrinsic fibers are produced by periodontal ligament and fibroblast, whereas the intrinsic cementum, which is seen in the cementum matrix, formed by the cementoblast. Okay, so two types of collagen fibers, and which has highest fluoride content. So cementum has the highest fluoride content and it is readily decalcifies in the presence of acidic condition. So it is easily decalcifiable and it has highest fluoride content because of its lower crystallinity of mineral component. Now the non-collagenous parts, we have proteins which play very important role in matrix deposition, initiation and control of mineralization and matrix remodeling. Basic non-collagenous proteins are bone sialoprotein, osteopontin, tenacin, fibronectin, osteocalcin. Few of them we had seen in periodontal ligament, and proteoglycans also we had seen, chondroitin sulfate, hyaluronic acid, heparin sulfate. So such proteoglycans are also seen in non-collagenous matter. So collagen we were discussing extrinsic and intrinsic. So now I talked about non-collagenous matter. And we have few growth factors and other cementum derived growth factors. Now we'll move on to the classification. This is very important. Acellular and cellular type. So acellular type, which is the term is a little bit unfortunate, because as a living tissue cells which are an integral part. So it is an integral part of a living tissue. Why acellular? Because some of the layers do not contain the cells in its lacunae. So that is why it's got this name. Acellular cementum is the first one to be formed, and sharpy fibers makes the most of its structures. And it forms during root formation before the tooth reaches the occlusal plane, and it covers the cervical one-third or the coronal portion of the root. It does not contain any cell which is more calcified, which the formation is slow, and arrangement of collagen fibers are more organized. Okay, so it is the first one to be formed, mainly sharpy fibers. Some layers do not incorporate the cell, one-third of the cervical or the coronal root portion. It is more calcified, formation is slow, and our collagen fibers are more organized in nature. So what about cellular cementum? Cellular cementum forms after the eruption of tooth once it reaches the occlusal plane. Okay, so its formation is also in response to the functional demand. So when there is a functional load, heavy load, there will be more cellular cementum deposition to bear the functional load. And Sharpie's fibers occupy a very small proportion, contains cementocytes in lacunae. This cementocytes is not present in acellular, that is why it has got this name, and contain these cementocytes which communicate each other with canaliculae. Okay, so there will be communication using canaliculae, and 2/3 of the apex part. So from this part to this part is cellular cementum, and this to this acellular cementum. Okay, so this is the 2/3 of root portion. Okay, this is cellular, and this little bit portion acellular, and its deposition is more rapid, and collagen fibers are irregularly arranged. So we have another classification, that is Schroeder and Page put forward this classification. It is based on the location, morphology, and histologic appearance. So let's see these 5 classification. The first one is Acellular Fibrillar Cementum, or AAC, Acellular Extrinsic Fiber Cementum, AEFC, Cellular Intrinsic Fiber Cementum, CIFC, Cellular Mixed Stratified Cementum, CMSC, and Intermediate Cementum. So it is based on the presence of cell, that is acellular, the first 2 types. The next 2 type is cellular and cellular. It has cells, and where it is located, few are intrinsic, few are extrinsic, and one is mixed. So always study with connection based on the types of cell and based on the location and morphology. So it will be easy, don't just by heart this. So let's see one by one. So what is Acellular Fibrillar Cementum? Okay, so this is formed at the most cervical enamel border following completion of pre-eruptive enamel maturation, and sometimes also during tooth eruption. It is probably secreted by cementoblast. So it is formed here. Okay, where it is formed most cervical enamel border after completion of pre-eruptive enamel maturation. There are 2 types of maturation: post-eruptive maturation and pre-eruptive maturation. So post-eruptive maturation takes longer period after the eruption. So the enamel will take up minerals from the saliva and GCF. That is post-eruptive maturation. Pre-eruptive maturation before eruption. So it happens, or it seen after following the completion of pre-eruptive maturation, and sometimes also during the tooth eruption. That is acellular fibrillar, without any cells, without any fibers. Fine. Now we have acellular extrinsic fiber cementum. So it forms both pre and post eruptively. It is secreted by fibroblast. Okay, this is secreted by cementoblast. AEFC secreted by fibroblast. On the apical portion of the root, it comprises a portion of the mixed fiber cementum. Okay, so here it is comprised of mixed fiber cementum. Otherwise it is acellular extrinsic fiber cementum. Now we have cellular intrinsic fiber cementum. So what is extrinsic, what is intrinsic, I talked here in the beginning. So hope you remember what is extrinsic and what is intrinsic. So cellular intrinsic fiber cementum is the third type. So it is formed both pre and post eruptively. It is synthesized by cementoblast but does not contain extrinsic Sharpie's fiber. Okay, hope you remember the extrinsic Sharpie fibers. So where there is intrinsic is written only intrinsic fiber, extrinsic is about Sharpie's fiber. So without any Sharpie's fibers. So these are formed or synthesized by cementoblast, just like acellular fibrillar cementum, and it does not contain extrinsic Sharpie's fibers. And the fourth one is cellular mixed stratified cementum, which is formed by both cementoblast and fibroblast. Okay, so it is combination of cellular intrinsic fiber cementum and acellular extrinsic fiber cementum. And we have the fifth one also, intermediate type. So intermediate type mostly seen at Cemento-Dentinal junction. So we have the 5 types: AAC, AEFC, CIFC, CMSC and intermediate type. So this acellular fibrillar cementum, there is no fibers, the cells are absent because it is acellular, no fibers, formed by cementoblast, location at coronal cementum. The acellular extrinsic fiber cementum, densely packed Sharpie's fibers because extrinsic fibers, so Sharpie's fibers. There is no cell because it is acellular, formed by fibroblast and cementoblast. Okay, and location cervical third of root. Cellular intrinsic fiber cementum, fibers are intrinsic, cells are there present because it is cellular, formed by cementoblast, location resorption lacunae. And the next one, CMSC, fibers, extrinsic Sharpies and intrinsic fibers, cells are present, formed by fibroblast and cementoblasts, location apical 1/3 of root and furcation. Intermediate cells are remnants of Hardwick's sheath and location Cemento-Dentinal junction. Now let's move on to the cementogenesis. So formation of cementum is known as cementogenesis. So again I tell you, if you don't know the Bell stage in detail, it is very difficult to understand the cementogenesis. So if you are studying gingiva, periodontal ligament, alveolar bone, cementum, so whatever you are studying, you need to have a very concrete base on the formation of tooth. So if you have a very good concept in formation of tooth, it's very easy to understand all the formation, the periodontal components, let it be periodontal ligament, cementum, alveolar bone or gingiva, because it is all a single unit. So cementum formation takes place along the root. Okay, so this is a root portion, so it takes place along the entire root. So at the advancing root edge, Hardwick's epithelial root sheath, or HERS, HERS, so it is a approximated, so advanced Bell stage, collapsing of the stratum intermedium happens, and the both outer enamel epithelium and inner enamel epithelium, it approximated and it is becoming a Hardwick's epithelial root sheath. So along the root side, it forming a sheath. which is derived from extension of inner and outer enamel epithelium. And this is possibly sends an inductive message to the ectomesenchymal cells of pulp. Okay. So the pulp of ectomesenchymal cells now differentiate into odontoblast, okay, and produce a layer of predentine along the thinner aspect of hers. So when this hers induct a message here, the dental pulp will produce odontoblast along the inner aspect of Hardwick's epithelial root sheath. Okay, so this is Hardwick's epithelial root sheath. This is the advanced bell stage. I just made a small portion of it. So once the dentine is dentine formation is underway, which breaks the Hardwick's epithelial root sheath. So it is now known as epithelial rest of molasses. So we have seen the same scenario in periodontal ligament. After the dental sac, it is giving rise to more collagen fibers and forming the periodontal ligament. So what happens here is the inner layer of dental follicle comes in contact with the predentine. So dental follicle is here, dental papilla is here. So hope you remember that bell stage: inside dental papilla, outside dental follicle or dental sac. So after the Hardwick's epithelial root sheath breaks and it becomes epithelial rest of molasses, the follicle which is present outside it will come in contact with the predentine. So this is the dental papilla, it will come in contact with predentine. So once it contact with the predentine, what happens? The cells of dental follicle now differentiate into cementoblast, which are the main cells responsible for cementum formation. So the cementum will be formed here, cementoblast. Okay, so that is how it forms. Hardwick's epithelial root sheath was there. When predentine is formed from the dental papilla, that is inside, okay, cementum is outside and dentine is inside, formed. The Hardwick's epithelial root sheath breaks, so that through that breakage the dental papilla enters and it differentiates into cementoblast and the cementum will be laid. So cementoblast synthesize organic matrix which is uncalcified and called as cementoid tissue or pre-cementum. So that is the uncalcified first part or the first form of cementum which is being laid out. So this is the cementoid tissue or pre-cementum. So it is uncalcified. It has the name pre-cementum, but it is uncalcified. It is also known as cementoid. Okay, it might be asked for a short note: cementoid tissue or pre-cementum. So that is about the cementogenesis. Hope you understood what is the concept. Now we move on to the mineralization. Mineralization begins at the depth of pre-cementum. So hydroxyapatite crystals are deposited first between and then within the collagen fibrils by a process that is identical to the mineralization of bone tissue. It is the same as the bone mineralization. Usually the width of this pre-cementum is around 3 to 5 micrometer, and this process of establishing an appropriate condition for crystallization and growth of the individual crystals in cementum, which is normally are extremely slow process and it extend over a period of several months. So it is a very slow process, mineralization. So the development of cementum has been subdivided into two stages. One is pre-functional and the functional stage. So pre-functional portion of cementum is formed during the root development and is extremely long lasting process. Okay, the pre-functional. So functional is starts when the tooth is about to reach the occlusal level and is associated with the attachment of root to the surrounding bone, and it continues throughout the life. It is mainly happening it is during the stage of adaptive and reparative process. So when there is functional changes, there is a lot of functional load will be there for the masticatory function and other functions. So the functional development is a continuous process and there will be continuous adaptive and reparative processes The cellular cementum we have seen based on the functional demand. Cellular cementum will be response to the biological changes or biological or functional demands of the cementum. So that's about the first part. I finished the basic features, physical characteristics, the basic type, cellular and cellular, the differences, and the shorter classification, 5 types, and the cementogenesis. Hope you remember the Hardwick's epithelial root sheath and how it is formed, and the pre-cementum and cementoid tissue, and the mineralization. We have 2 stages, pre-functional and functional. Now the next part I will be covering about the cells, mainly cementoblasts and cementocytes, cemento enamel junction, and basic functions of cementum. So now we are in the second part. So this session is about the cells of cementum and its functions, and little bit about the developmental anomalies and other problems seen in cementum. So we have 2 types of cells. They are cementoblasts and cementocytes. Cementoblasts are, which is derived from dental follicle. Okay, hope you remember dental follicle giving rise to cementum, periodontal ligament, and alveolar bone, whereas the papilla giving rise to pulp and dentin. So the transformation of mesenchymal cells of dental follicle giving cementoblast. So these cementoprogenitor cells synthesize collagen and protein polysaccharide. So these cells have numerous mitochondria, a well-formed Golgi apparatus, and large amount of granular endoplasmic reticulum. So while seeing the histology, the root resorption areas are showing that the cementoblasts can arise wherever viable dentin is exposed to the soft tissues of periodontal ligament. So the induction of cementoblast from periodontal ligament cells can apparently take place throughout the life, as evidenced by the physiological areas of cemental repair. So the cemental repair will be happening throughout the life. Wherever there is loss of tissues happen or resorption happens, the cementoblast will act and produce new cementum. So cellular turnover among cementoblasts is slow compared with that in the osteoblast. So the bone and cementum are adjacent. Between these two we have periodontal ligament. So the turnover rate is comparatively low in cementum compared to the alveolar bone. Furthermore, it appears that cementoblasts are capable of altering the rate of cementum deposition. Whereas the cementocytes in lacunae and the channels in which their process extend, which are known as canaliculi. So canaliculi are the extended processes. Cementocytes are seen in lacunae, and the central cell mass may appear round or oval, which is having 8 to 15 micrometer, and the cytoplasm is palely basophilic, and the nucleus is centrally located. It has a central nucleus with basophilic cytoplasm. So cemento enamel junction is another feature. We know what is cemento enamel junction. It is the boundary between the tooth crown and root in clinically, but anatomically it is a junction between enamel and cementum. So it has basically 4 types. So the first type is cementum overlaps enamel. The cementum overlapping enamel 60%. Second one is cementum meets at a point. Cementum and enamel meets at the cervical end. And 10% enamel and cementum does not meet, and 1.6%, that is the least, where the enamel overlaps cementum, that is the least percentage. Most common is cementum overlaps enamel. If the cementum is not meeting enamel, there will be exposed dentin, because root dentin is covered by cementum. So exposed dentin means there will be chances of hypersensitivity. So CEJ can be located various methods like conventional, modified, tactile by visual method using probes, bite wings, RVG. So we can use many probes like Florida probes, perio probes. So many probes are there to locate CEJ. So another junction is Cementodentinal junction. So it is the terminal apical areas of cementum where it joins the internal root dentine is called as Cementodentinal junction. Okay, the apical area of cementum. This is the apical area of cementum where it joins with the internal root dentine. So it joins with the internal root dentine is known as Cementodentinal junction. So the nature of CDJ is of particular importance because it forms an interface between two very different mineralized tissues. Okay, these are the two mineralized tissues, cementum and dentine, and it is also of clinical importance because of the processes involved in maintaining tooth function while repairing a diseased root surface. So it is of clinical importance because it has repairing functions involving repairing of a diseased root surface. It is 2 to 3 micrometer. Now let's move on to the functions. We have 3 basic functions: anchorage, adaptation, repair and resorptions. In anchorage, it is to furnish a medium for the attachment of collagen fibers that bind the tooth to the alveolar bone. So the connective tissue attachment to the tooth impossible without cementum. Okay, so we know that periodontal fibers are giving anchorage, so it is attaching to the cementum. So without connective tissue it is not possible. So in hypophosphatasia, where the the element of cementum is missing, loosening and premature loss of anterior deciduous teeth occurs, that itself showing that without cement there is no possibility of anchorage, and the exfoliated teeth are characterized by an almost total absence of cementum. Okay, so that is a clinical evidence of cementum and its anchorage. Whereas adaptation, the second one, it is a continuous deposition of cementum is of functional importance because cementum is not resorbed under normal condition. As a most superficial layer of cementum, as age increases, a new layer is deposited that keeps the attachment apparatus intact. So a new layer will be continuously deposited. It is happening throughout the life. The repair process, it is a major reparative tissue for root surfaces. So damaged roots such as fracture, resorption can be repaired by the deposition of new cementum. And resorption of cementum. Cementum, although is less susceptible to resorption than bone, but it is carried out by multinuclear odontoclast. So sometimes question might ask, what is the functions of odontoclast? It is a multinucleated giant cell. It causes destruction or resorption and may continue into the root dentine. So what are the factors of resorption? So we have local factors and systemic factors. Local factors are trauma from occlusion, orthodontic movement, pressure from malaligned erupting teeth, cysts, tumors, teeth without functional antagonist. If proper antagonist is not there, that also a chance of resorption. Embedded teeth, replanted and transplanted teeth, periapical and periodontal diseases. Whereas the systemic factors, calcium deficiency, it could be due to hypothyroidism, hereditary fibrous osteodystrophy, Paget's disease, and also could be an idiopathic reason. So cementum resorption appears microscopically as bay-like concavities on the root surface. So these multinucleated giant cells and large mononuclear macrophages, they are generally found adjacent to the cementum which is undergoing active resorption. Okay, so resorption occurs most commonly in the apical third, than middle third and gingival third. So here it is the most common site of resorption. So it is always associated with the multinucleated giant cell. I said odontoclast or cementoclast. Now let's see few anomalies. We have covered in detail about the anomalies, but especially the cementicles. So cementicles are small globular masses of cementum which is found approximate in around 35% of human roots. So may not always be attached to the cementum surface, but may be located in free as a free appearance in periodontal ligament. These may be result from microtrauma when extra stress on Sharpie's fibers cause a tear in the cementum, and they are more commonly found in the apical and middle third of root, and also in root furcation areas. And it may develop from calcified epithelial rest and spicules of cementum or alveolar bone when it is traumatically displaced. Next one is enamel pearl. We have seen, so in some of the Hardwick epithelial root sheath cells remain attached to the forming root surface, they can produce a focal deposit of enamel. That is known as enamel pearl. So which is plaque retentive structures which promote periodontal disease. They look like calculus, but it is actually enamel pearl which cannot be sealed off or scaled off. We cannot remove it in scaling procedure. And some of the abnormalities of cementum, we have many abnormalities. The most common one is cemental hyperplasia. Hyperplasia means over functioning. So hypercementosis or cemental hyperplasia, it is abnormal thickening of cementum. There will be large amount of cementum compared to the normal one. It is a largely an age related phenomenon. It can be localized to one tooth or maybe generalized, affect the entire dentition. So if the overgrowth improves the functional qualities of cementum, it is termed as cemental hypertrophy. If the overgrowth occurs in non-functional teeth, or if it is not correlated with increased function, it is known as cemental hyperplasia. Okay, so these are different. What is cemental hypertrophy and hyperplasia different? Hypertrophy is if the overgrowth improves the functional qualities of cementum. That is not a problem. It is improving its functional quality. That is known as hypertrophy. But if the overgrowth occurs in a non-functional teeth, or if it is not correlated with increased function, that is known as hypercementosis or cemental hyperplasia. So it occurs as a generalized thickening of cementum with nodular enlargement of the apical third of the root. It also appears in form of spike-like cemental spikes created by either the coalescence of cementicles that adhere to the root or the calcification of periodontal fibers at the site of insertion into the cementum. It is usually associated with situations like teeth without antagonist, teeth with pulpal and periapical infections. So hypercementosis of entire dentition may be seen in patients with Paget's disease. So Paget's disease is a bone disease that is problem associated with bone formation. So in that case also hypercementosis can be seen in a generalized form. So some of the other problems are seen hypercementosis are acromegaly, calcinosis, thyroid goiter, arthritis. And treatment is basically does not need any treatment. It could pose a problem if an affected tooth requires extraction. So if extraction, we don't go for a normal extraction. Instead, a surgical extraction is opted. Cemental aplasia or hypoplasia. Hypoplasia means normal function is not happening. So hypophosphatasia, there is an absence or paucity of cellular cementum. So hypophosphatasia is due to an inborn error of metabolism. The basic disorder is a deficiency of enzyme alkaline phosphatase. So due to that, there is no proper cellular cementum or absence or paucity. So this is characterized by loosening and premature exfoliation of deciduous teeth, mainly anterior. So cemental hypoplasia means there is no proper cementum, so this anchorage function is impaired, so there will be loosening and premature exfoliation. So exfoliated teeth microscopically show complete absence of cementum or isolated areas of abnormally formed cementum. Cemental tear is another thing, that is a detachment of a fragment of cementum, is known as cemental tear. The last one is ankylosis. Ankylosis is fusion of cementum and alveolar bone. So cementum and alveolar bone will be fused and obliteration of the periodontal ligament space. So if periodontal ligament space is not proper, there will be fusion. So results in resorption of root and its replacement by bone tissue. This condition is uncommon, occurs in teeth without cemental resorption, and it represents a form of abnormal repair. So it can also occur after chronic periapical infection, tooth reimplantation, occlusal trauma, and more common in primary dentition. Okay, so this periodontal ligament space is obliterated, so the cementum will be joined with alveolar bone. So there will be very problem facing in extraction. So clinically there will not be any physiological mobility, and periodontal ligament space is replaced with bone in ankylosis, so proprioception is lost. Teeth have special metallic percussion sound, so we can make out whether it is ankylosed or not by tapping on the tooth. We will get a metallic percussion sound. So when cementum is exposed to the oral environment, in cases of gingival recession, there will be an pocket formation, there will be hypersensitivity. So that's all about cementum. So we were talking about the cells, cementoblasts and cementocytes, and we discussed about cemento enamel junction and its 4 types, cemento-dentinal junction and its various functions, anchorage, adaptation, repair and resorption, and the developmental anomalies associated with cementum, that is cementicles, enamel pearls, cemental hyperplasia. I told you what is hyperplasia and hypertrophy. Cemental hyperplasia or hypercementosis, cemental aplasia or hyperplasia, that is hypophosphatasia, and ankylosis. So these are the short notes, like cemento-enamel junction is a short note. All these are short notes: cementicles, enamel pearls, hypercementosis, and the functions of cementum, and cementoblast, cementocytes are again could be a short note. So I will come up with our next topic, alveolar bone, in my next sessions. Hope you understood about the cementum. Cementum is a little small topic compared to our periodontal ligament and gingiva, but questions will be asked. In the first session we had seen the cementum and its basic characteristics and the parts of cementum, that is cellular and acellular cementum. So I'll come up with alveolar bone in my next session. Thank you.